Bingo.
All right, guys, we're going to go ahead and get started. Guys, we're going to start. Sorry, I don't talk loud. Alrighty, we're going to go ahead and get started. Welcome, Dr. Marc Zwillenberg.
Oh, thank you. Hey, I'm Marc. I'm one of the PGY2s. Thank you to everyone for helping me prepare for this presentation. I'm going to be talking about hemophilia and specifically concentrating on the dosing of factor in the ED. So we've got some learning objectives, a little bit about the background of hemophilia. I'm talking about essentially how this kind of how we can talk about hemophilia. Talk about the degree of hemophilia, common presentations, talk about the dosing of factor replacement therapy, and some adjuncts to therapy briefly. So just a brief kind of generic case. You have a 34-year-old male, has a history of hemophilia. He was a bicyclist and he fell onto his right knee. He has stable vital signs, his ABCs are intact, and he has right knee pain. So the first question you want to ask yourself is, what kind of hemophilia does this patient have? So you want to just talk about there are three kind of main types of hemophilia. By and large, the most common hemophilia is hemophilia A, which is a deficiency of factor 8. You have hemophilia B, which is a deficiency of factor 9. And you have hemophilia C, which is a deficiency of factor 11. Hemophilia A, again, most common. Hemophilia B is uncommon. And then you have hemophilia C, which is even less common than that, which primarily presents in Ashkenazi Jews. So shout out to all of the Ashkenazi Jews in the crowd, including myself. Oh, okay, here is X-Pac to remind you that he is here. I think he is a Hall of Fame wrestler. But anyway, he is here to remind you that hemophilia is X-linked, so you're primarily going to see it in males, but you can see it in females. So a little bit about the degrees of hemophilia. So you have a spectrum from mild to severe. Mild, you'll have 5 to 40% of factor. They basically bleed relative to the rest of the population, so they're essentially kind of normal. You have moderate, which is 1 to 5% of factor. They'll bleed about once a month, have like one bleeding event once a month. And then you have severe, which is people who have less than 1% of factor, essentially zero factor, and they can bleed up to 1 to 2 times a week. Most patients do have severe disease, and of course in the emergency department, when in doubt, always consider or assume severe disease. So the bleeding injuries are essentially, the common things are common. The hallmark bleed is of course hemarthrosis, but they're just more susceptible than the general population to things like GI bleeds, subcutaneous bleeds, hematomas, bruising, dental bleeding. And then of course brain bleeds are not particularly more common in hemophiliacs, but when they do happen, they carry a very high mortality. So now kind of the meat here, we're talking about dosing of factor replacement. It's really kind of simple. For hemophilia A, which is again the most common, for every 1 unit per kg of factor 8 given, you're going to raise your total percentage of factor in your body by 2%. And then for factor 9, which is hemophilia B, for every unit per kg of factor given, you're going to be raising it by 1%. Every type of bleed has a different type of target percentage that you want to look for. And here's basically a chart that I found, which is a little busy, and I kind of wanted to not necessarily dumb it down, but make it a little bit more concise for our purposes. So essentially you see all here, you see all the joints, muscle hemorrhage, and then of course the major trauma with all these different ranges. But if you go to my chart, which I decided to make, you really kind of have these two kind of main categories. You have major trauma, GI bleeds, brain bleeds, or epistaxis, and then you essentially have anything else. So for the first category, like major types of bleeds, like major trauma, GI bleeds, brain bleeds, and epistaxis, you want to get to 100% of active factor. So very simply, it just means for hemophilia A, you want to get to 50 units per kg of factor as a bolus. And for hemophilia B, you want to give 100 units per kg for a factor 9 bolus to get to 100% of active factor. And then anything else, which includes hemarthrosis, muscular bleeds, gingival bleeding, things that you're concerned about, you want to get to half that, so 50% of active factor. So that means 25 units per kg for hemophilia A and 50 units per kg for hemophilia B. So what if you don't know? Because someone could come in, maybe they have a history, so if someone in the family who has hemophilia and they happen to be bleeding, they could have hemophilia, but you don't know which type. You can always give FFP. Every unit of FFP will raise factor 8 and 9 levels by about 3 to 5%. What else can you give? So patients may have inhibitors because they get these constant boluses of factor during their life, and then they develop these antibodies, and they can become actually pretty, they can become pretty resistant to these types of factor treatments. So three things that are considered are FIBA, which is a factor VIII inhibitor bypass activity agent, which is basically an immunologic agent. Then you have activated prothrombin complex concentrate, and then you have recombinant factor VII. All these things, there's like very conflicting data about what works better, whether one is inferior to the other. Most importantly, what you really want to do is make sure you get hematology on board at this point if you have someone with a history of having resistance to kind of the traditional factor replacement therapy. Oh, okay. Otherwise, you really want to look at resuscitation, which is business as usual. Obviously, you want to consider your ABCs. You want to give factor replacement as soon as possible. If you can give FFP if the diagnosis is uncertain. Obviously, if you're concerned about major bleeding, give blood products early and give, and make sure you give them. And then, of course, admit versus discharge and consultation with hematology. For most of these patients, they're going to need several days of factor replacement therapy. If they have a good hematologist and they're stable with good follow-up, then they can probably be discharged. However, in most cases, or if someone doesn't have a hematologist, you may need to admit them just for more days of factor replacement therapy. So for our case, just to kind of summarize things, he has a right knee effusion, which is concerning for hemarthrosis. Patient has hemophilia A. He weighs 100 kgs. So what do? You give a 25 unit per kg bolus, because this is not one of those major bleeds that we talked about, which amounts to 250 units of factor VIII, and he's going to get 1 to 3 days of factor replacement therapy. And he has a pretty good hematologist, so I guess we can discharge him. So take-home points. Glass is empty. You need to assume severe disease. Everyone has severe disease, so you need to basically work as if you're starting from scratch. Take home 2, for major traumas, GI bleeds, brain bleeds, or epistaxis, you want to get to 100% of active factor. Take home 3, anything else, give 50% of factor. Take home 4, my chart as a quick reference, basically in a pinch, this is what I think we should be doing for hemophiliac patients who are bleeding. If the diagnosis is unknown, give FFP. If, antibodies, you need to consult hematology because they ultimately will have a better idea of what to give in these kind of refractory types of situations. That's basically it. Questions? The blood gift. Okay. Yeah. Oh, yes. Yeah.
I had a patient on Juve who had this and was stabbed in his leg and was having expanding hematoma. First off, it took like 3 hours of yelling at people to find the hematology fellow so that he could approve the factor, which was ridiculous. But anyways, the point of the story is that you always need to ask what company of factor they use. Because apparently the companies of factors, there's 2 different ones. They have different kind of like other things in the solution. So sometimes it's always supposed to be the same company, because if you get the other company, they might have a reaction or whatever it is. So I always ask which company, because all these people, if they have known hemophilia, they'll have their own factor at home. So first off, if they have their own factor, you can say, oh, you're bleeding, do you have your factor? They can say, yes, well, let's give it to you.
Yeah.
That's fine.
Yeah.
You can't find whatever's in your department. On top of that, though, the 2 different companies are very annoying because the way it works is they come in vials, and the vials is like, one company is like each vial is 100 units, and the other company each vial is 20 units. And so it's like, I needed to give for how much, like 250 or whatever. And so the fellow wouldn't approve 3 vials of one to get to the 250. And so I had to have like 2 of the one vial and then some of the other vial. And it's very confusing and very difficult. So basically, always ask your hemophilia patients what company they use and if they have their own factor. Because then you can just give their own, and it works better and faster and easier.
Yeah, I was reading like patients typically have their factor with them if they know that they have hemophilia, and you can trust them and have them administer. Well, you can administer it. Yeah. Yes, please. I think the big one. How many days? Yeah, sure. Here.
Yeah, so like I'm imagining.
So he had kept just because it was. So he had kept because it was trauma and he had expanding things on his legs, so he needed to be kept for other things. I mean, so I've never had that experience. I guess we could describe it.
I would coordinate with different problems.
They'll come back. Can you take a look though at the longest ones, like GI hemorrhage, right? They're going to be in the hospital for a while. They're going to have GI bleeding,
Yeah, let's
right?
say it's a hemorrhagia.
Yeah, most of the time, you'll coordinate with hematology. They might be able to go home, but a lot of times they're going to stay in the hospital and wait for a day to make sure that the bleeding doesn't continue to expand.
Right.
So they might even come, right, it's only 1 to 3 days. So by the time they're there the next day, that might be the second day. That's the only they need to make all of that.
They can also, and they'll call their hematologist and they'll reorder for them.
Correct. Yeah. A lot of
It's a
times-
much better system.
Yes.
So let their own hematologist reorder.
Yeah.
Because then they know they got treated. So it's good.
Yeah.
But most of the hemoarthrosis is at home.
Yeah.
You give them 1 dose and they're home. And that 90% of the patients are just hemoarthrosis. And then they bring the factor themselves. They bring their own stuff from the refrigerator at home and give them that.
Yeah.
You know, we usually don't let patients give their own drugs. This is the exception.
The hospital has like a very limited supply of this, so like, if they end up coming in, it's probably they're gonna get like the first dose from us, and the rest is gonna come from other hospitals if they're able to. Because they have like enough for like 1 or 2
Yeah.
patients.
New York City
That's
blood.
the one thing.
Yeah.
Yeah, why does epistaxis warrant the same aggressive management as the GI and the brain?
Yeah, I didn't read too much into it. My only thought is just that epistaxis can, like we've seen really bad nosebleeds. You know, they can keep on going and going and going and going. So I mean, that would be my thought.
Because it is compressible, theoretically.
Yeah.
Guys, I think we have to move on.
Oh, okay. No problem. All right.